introductions. If I could ask IPAT members to go ahead and introduce yourselves, and then we'll have folks that are joining us as participants introduce yourself in the comments in the chat. That would be terrific. And I will go ahead and get started. My name is Amanda Timmons. I am a policy analyst with the Oregon Immunization Program, and I'm going to be your host today, or your facilitator today, more specifically. And I'll pass it along to the next person.
Amanda, do you want to call us out? It might be easier that way.
I actually don't have a list.
I can do that. Hang on a second. Let me pull it up.
Let's mute folks.
Alana Braun, you're up.
Yeah, sorry, and you want us to do introductions, is that right? Or,
yeah.
Okay. Great. I am Alana Braun. I use she, her pronouns. I am a pediatrician representing OHSU pediatrics.
How about Becky Sherman here?
He's not in the list. The participants list.
Okay.
Becky's going to be late, Anne.
Okay. Amy Kirkbride. Let's see who's next. Cindy, let's have her go next. Cindy D'Angelillo.
Oops, sorry there. Yeah, it's Cindy. I'm a registered nurse, recently retired public health immunization coordinator from Benton County. And I'm just joining as an interested member of the public. Thank you for having me.
Deborah Rumsey.
Hi, sorry about that. My name's Deborah Rumsey. I'm the Executive Director at the Children's Health Alliance and work with independent pediatric practices.
Kelly McDonald.
Hi, everyone. Kelly McDonald. I am the Immunization Policy Project Manager here at the Immunization Program.
Kim Bartholomew.
Good afternoon. I'm Kim Bartholomew, Beaverton School District Nurse, and I represent Oregon School Nurses Association.
Christy Polanco.
Hi, good afternoon, everyone. Christy Polanco, Innovator Agent with the Oregon Health Authority with an External Relations Division.
Lisa Chambliss.
Hi, Lisa Chambliss, Lane County Public Health Communicable Disease Nurse. She, her pronouns.
Molly Sachs.
Hi, everyone. I'm Molly Sachs, Program Coordinator with Immunize Oregon.
Stacy. Stacy, are you out there? Stacy's here, but she's shy. Teresa Everson.
Hi, all. Teresa Everson. I use she, her pronouns. I'm the Deputy Health Officer for the Multnomah County Health Department, and I am a Health Officer representative.
Looks like that's everyone that's here for the moment. So
Great.
back
Thank
to
you,
you, Amanda.
Anne. Thanks. I would encourage you all to take a look at the chat just to see who else is joining us today. We've got a wide range of people and we've got a wide range of geographic locations in the state, which is awesome. I love that. Okay, so I'm going to jump directly into our first item, which is legislation update. And I will start. We are winding down on the legislative session, and I, for one, am really, really grateful. The final day is estimated to be June 18th, but according to the law, they have to be done by June 22nd, which is a Sunday. So we know that we have less than 30 days left in this session. For the most part, it's been a relatively quiet session for immunization. There were a lot of bills early on, but most of the deadline, which again, so much of the time we're playing defense, that was actually good for us. I did want to highlight House Bill 3284, which has passed the House and is in committee in the Senate. A amendment was made to that bill. That bill initially would have allowed physical therapists to vaccinate in their clinics, but an amendment was made that took that provision out. So we're not really tracking that one anymore. But I think that's about it for me, but I would like to pass it on to Kelly McDonald to talk about Senate Bill 42.
Hi, everyone. Just a reminder, Senate Bill 42 would provide funding to sustain the vaccine access program. So it currently includes $5 million for a vaccine cost. That's for billable vaccine for vaccine access program providers. Again, a reminder that that money is replenished, 100% is replenished as those providers bill for doses administered to insured clients and then pay us back for the cost of the vaccine. So we can just then continue to use those dollars to purchase more vaccine. So $5 million for vaccine and $1.8 million for operations. That would cover about 5.5 FTE to support the program. There was a Senate Healthcare Committee hearing and work session a few months back. In April, that bill was referred to the Joint Committee on Ways and Means where it sits today. So we are just waiting. We have heard from folks who are doing a lot of advocacy on this bill that there's some concern about the fiscal ask just because there is a lot of uncertainty in light of the state revenue forecast being lower than expected. And so we don't know really what to expect. The Joint Ways and Means Committee will do with that bill, but that is still where it sits. And as Amanda said, we have a few more weeks here to wait and find out. That's it. Thank you.
Thank you, Kelly. It's sometimes hard to wait to hear on these things because I know that legislation is really important to lots of the clinics that are out in rural areas and that serve at-risk populations.
Yep.
Okay, so I'm going to move on to Vivian Larson. She's going to talk about immunization data and where you can find it. Vivian?
Great, thank you so much. I'm just going to share my screen really quickly. Thank you so much, Amanda. Hopefully you all can hear me. My name is Vivian Larson, and I'm an epidemiologist within the program, Oregon Immunization Program. And today I'm going to present to you a bit about our data visualization efforts that we have released publicly, and then also tell you an update of the state of immunizations in Oregon to date. So that's just the update from the first 2 quarters of 2025. Before we get into data, what I wanted to do is to start off by sharing the breadth of data we do share publicly online. And this comprises a list of all of our publicly available dashboards that are on our Tableau public profile. And this is a list that's current as of June 2025. I broke it down by update frequency, A referring to annual, W weekly, monthly, and then everything else is yeses and nos. Whether we go as granular as zip code rates, yes, no. Demographics, do we break it down by age, sex, race, ethnicity, and then also data available for download. And this is specifically for CSV or Excel files, so that individuals may produce, figures and graphs that suit their needs. Briefly, I just want to go through this chart just to reiterate the kinds of things that we do release and make available publicly, and then to also highlight some things that are pending that are going to be coming up pretty soon. So first and foremost, we have child immunization rates. This is the 2-year-old annual process that we go through, pretty granular. We get down to the zip code, we make it available for download as well. We also produce an annual adolescent immunization rate data. This includes a snapshot of 13-year-olds as well as the larger adolescent group, which includes 13 to 17. We produce annual school immunization rate data that includes immunization and exemptions. Currently, we release data at the level of the county as well as the state. Very soon, we're going to be releasing school level data. So that gives you that real picture of what the state is of school immunization rates within Oregon. We also produce an annual dashboard that includes adult immunization data. This is pending update. We're going to be adding a few more years, and so you'll be able to see trends over time, which is really exciting. That's to come in 2025. During flu season, we also update our dashboard on a weekly basis. So we do produce flu immunization rate data. We do this on a weekly basis, and that update really begins at that first week of October, all the way through when we see that tail, that consistent tail of immunization. So at the end of February, beginning of March. We also produce a measles immunization rate dashboard that includes children from 1 through 18 years of age. That's updated on a monthly basis. And we continue COVID immunization updates as well on a monthly basis. We've been doing that since the time of COVID. And a brand new dashboard that we just released is a state-supplied vaccine provider dashboard. This provides contact information and also the location information of providers across the state who participate in state-supplied vaccine programs, so VFC or VAP. So I did hint that I was going to share some upcoming information, so that's what I'll do now. We will anticipate releasing pregnancy immunization rate dashboard. So that includes immunizations that are recommended during pregnancy. That is to come in 2025. And we're also beginning planning phases of a perinatal hepatitis B dashboard as well. So exciting stuff to come. Now that we've gone through, and I should mention, this is available this sheet is available I'm happy to share this out. All of these are active links that link directly to the dashboard. So it makes it for easier access to all of our data. So I'm happy to make that available as well. Okay, so now that we've gone through what data we have available, let's just go through a quick update of data that's been updated in Q1 and Q2 of 2025, and that includes childhood, adolescent, and school data. So the 4313314 rates, they had been steady at 71% between 2019 through 2021. We have seen a more recent decline all the way into the most recent update, which is the 2024 cohort of 2-year-olds. We've noticed that this has actually regressed down to the 2017 levels. Now, what we publicly release is data from 2018 on. So historical data that we have from 2014 to 2018, hopefully we can get that included into our dashboard at some point in time. I do want to note that the drivers of this really, of that 43314 rate, are the DTaP and PCV, right? There's 4 doses required for that completion. So as I mentioned, this is what we're seeing today is hinting back towards what we saw in 2017. Now, this is the historical data, snapshot of the PDFs that we used to release and produce and release online. And as you can see, from 2014, we started off at 60% for the 431, 3314 series completion, up-to-date rate, excuse me. And all the way up to 2019, that went to 71%. So over a 10 percentage point increase over that span of time. And today, again, we are sitting at 68.4%, so a bit of a regression from where we were previously. The declines that are seen are across the state, and they're not unique to rural or urban counties, and there are disparities by race, ethnicity that still remain. And this is an example of the zip code level data that we do release on our dashboards, and you can see that the rates at the zip code level vary quite a bit, right? From less than 50% all the way up to greater than 80%. And so having this granular data is really effective in understanding the differences that we see even within counties. Now we're moving on to adolescent data, and adolescent immunizations are holding steady in Oregon. The rates for Tdap, MCV, and HPV completion have stayed fairly steady for the past 4 years. And this down here is a figure that represents the 13 to 17-year-olds in Oregon. And I think it's important to note that we don't see much change here year after year. It's pretty steady. And that's because you're looking at a larger group. And so in order to see change, I think it's more effective to look at the 13-year-olds, right? A lot of the recommendations hit in that earlier years in the adolescence. And so that the snapshot of 13-year-olds really indicates where things are going with this group. And so in looking at the 13-year-old data for Tdap, MCV, HPV, we see we dropped off a bit in 2021, but then we see this kind of gradual steady increase. It's minor, but it's kind of a promising trajectory. We do continue to see significant disparities in HPV vaccination across the state, right? With urban regions trending towards higher HPV completion rates. But there are some things that the data doesn't tell us. And I think that's an important reminder for us that for those of us who do work in data, for those of us who work in the community setting, that information is complementary, right? We can't necessarily draw all the necessary conclusions just by looking at the data. We need to understand context. So we have context to understand that many rural regions, which have focused on HPV vaccination in the past, they continue to have high rates. And so again, having that contextual information really gives richness to our data and understanding the patterns that we're seeing. So it's a good reminder that we need both. Last but not least, we'll talk about school statewide immunization rates. This was also updated in Q2 of 2025 with the new data. So this graph here represents or is the data for the immunization rates for kindergartners. And down below, we have the non-medical exemption rates for kindergartners as well as medical exemptions down below. And as you can see for the immunization completion, that we sit about 86.3% for Oregon in 2025. And down below here, we see non-medical exemptions for any. So that's 1+ non-medical exemption vaccine for any of the school required vaccines. We're sitting at about 9.7%. The data alone, right, those single points are concerning. But what is the takeaway here is that the statewide immunization and exemption rates really don't tell the whole story, and they're masking what's happening within counties. And when it comes to schools, the more granular I feel, the better, right? Schools represent a congregate setting where children gather together on a regular basis. And when it comes to disease spread, especially vaccine preventable diseases that are communicable, that's a prime location where spread can occur. So let's start with the immunization rates. Statewide school immunization rates mask low rates across the state. And if we go back to that value is 86.3%. This is a snapshot of the dashboard that we produce. This is for the complete individuals who are complete for school required vaccines. And looking at our waterfall chart here, we see that counties really range from 61.5% all the way down to 92.3%. And I want to reiterate, statewide was 86.3%. So the statewide value is a good tool, but it doesn't tell the story of what's happening within Oregon. Similarly, with non-medical exemption rates, we had a statewide 9.7% for 2025 for Oregon. This is again non-medical exemption for any. So 1+ school required vaccine, a child has an exemption for any one of those, a non-medical exemption for any one of those. If we look again at our waterfall chart, the range is 38.5% all the way down to just above 5%. So I want to put that into context of what that means. 38.5% of children in this county have a non-medical exemption for 1+ vaccine. And this is kindergartners specifically, right? One thing to note about this chart is that historically, you would see purple, this indicator color, for counties that have less than 5%. That's kind of our cutoff for indicating maintaining that low percentage of non-medical exemptions. This is the first year that we've seen that indicator drop off. So not only are we kind of seeing that historical high for non-medical exemptions, we're also seeing that shift across all of our counties. So it's not just what's happening across counties that's important, it's also important to look at that trajectory over time. And again, this is kindergarten. Whenever we look at that trajectory, that timeline of occurrence, we're looking at kindergarten specific data for that snapshot of what the whole entire population of school children, what their immunization data looks like. That snapshot is, it's useful to look at the K-12 for the full population of kids. So again, kindergarten specific, since 2021, here's our indicator, 2021, statewide non-medical exemption rates for any vaccine, again, 1+, have steadily increased. And again, that's that top purple line, that's for any one vaccine. In 2021, we were at 5.3%, and we're seeing, again, that historic high of 9.7% in 2025. The ones that are leading that rate are DTaP, MMR, that second dose of MMR, and polio. They all have a non-medical exemption individually above 8%. Okay, so now that we've talked about the updates, there are a couple ways that you can find our immunization rate data. One of them is to go ahead and Google OHA immunization program. And it's the first hit that you'll see here. That'll take you to our homepage. You'll go to the right column and click on our data and reports link, and that will take you to the data and reports page. Each of these are active links that take you to the dashboards represented. So clicking on this will take you specifically to the 2-year-old dashboard. This will take you to adolescent, so on and so forth. Something that's brand new that just was updated in this last month, we have a quarterly data snapshot. So it's really difficult for us to communicate when we make changes. Unless you're an active user of our dashboards, it's really difficult to notice. Maybe we release zip code level data or get more granular with other things. Like I said, school level data is coming up. So it's difficult to catch these changes and to communicate those out. So we decided to develop a quarterly data snapshot that really details all of this information in a one-stop 2-page overview. So this is what it looks like, a quick paragraph on the plans, what we've updated, what are things to come, and then 3 basic snapshots of updates that have occurred. So if there's interesting findings, if we've, I think in Q1, we released zip code level data for 2-year-olds, that was highlighted. The new data for schools was provided in Q2. So examples of new data, highlights, new releases, things like that to keep note of. And these have all active links. So if you click on, it'll have a link to the dashboard that's being referenced. So it'll take you directly there. The other way that you can get access to, I should mention before, the other way that you can get access to our immunization rates is to also just Google Oregon Immunization Program Tableau Public. That'll take you directly to our Tableau Public homepage for the Oregon Immunization Program. And there you'll see a nice grid of all of our dashboards nicely laid out for you to bookmark and to keep as a reference. So with that, I'd like to thank you for your time. I'm happy to answer any questions.
Any questions for Vivian? Okay, well, not seeing any. Oh, one question in the chat. Will OIP publish influenza rates for elders in long-term care?
That's a great question. Have no, the data that we publish is out of alert, and we don't have an indicator of that information of residents. We can't necessarily determine that. So we publish 65 plus specifically, but not necessarily by congregate setting.
Cindy, when Dr. Cieslak gets here, that would be a great question to ask him about too. He's coming in late today to the meeting.
Okay.
Yeah, and this is Rex Larson, the Surveillance and Quality Manager with OIP. You know, many of you probably will remember that we did publish COVID rates for elders in long-term care during the pandemic. So there has been some renewed interest in both flu and COVID in maintaining those. Right now, there is a healthcare workers survey that goes out, and it does include long-term care facility employees. But there's been some interest in either expanding that to include residents or finding a way to link residency status with alert data. It would require probably some statutory or rule changes, though, in partnership with DHS. But it's come up a few times in the past couple of years. So it wouldn't surprise me if it is something we work on in the future, but it's more complicated than we wish it was.
Agreed. I'm looking forward to the day when it's there.
Thank you, Cindy. Any other questions for Vivian? Okay, we'll probably have time to revisit questions at the end of the meeting, so we can do that if anything does come up. Next, we have Mimi Luther, and she's going to talk about Project Horizon.
Thanks, Amanda. Hi, everybody. It's great to see so many people here and so many newcomers too. I want to invite everybody, members for sure, but also guests. Please feel free to introduce yourself in the chat. It's a great networking opportunity for everybody that's in the room. So for those of you who don't know what Project Horizon is, it's the name of the effort that we've been working on for about a year to prepare for this very month when we begin a very serious downsizing of our program and with some impact on the services we're able to provide. So that's Project Horizon. The latest update is that this month we will lose 9.5 full-time equivalent staff. Those are people that have been here anywhere from 1 to 13 years. All of them subject matter experts in their own right. We'll lose another 2 in July. We are keeping 7 of the limited duration staff that we have had for the last several years to help us sort of cut the rate at which we downsize and be good planners about it. We're in a place right now where we're working to finalize our decisions on what to cut and how, and what to continue, how to continue doing process improvement on the services we have left so that we're being as efficient as possible. And we really can't make any decisions until we know about the outcome of Senate Bill 42. If Senate Bill 42 doesn't pass, that'll have very serious impacts on our decisions and the volume of services that we'll have to downsize. So that's my quick update. Does anyone have questions? Thank you, Cindy.
Yeah. Is IPAT on the chopping block?
No. Great question. So we have two formal advisory committees. One is in statute, the other is not. IPAT is not in statute, but we've been doing IPAT for more than 20 years. And it's invaluable for us, so it will not be going away. The other committee is the ISAC, the Immunization School Law Advisory Committee, that helps us with the entire process of what and how and why certain vaccines are required in schools. And that's a statutorily required committee, and it'll stay that way. As far as I can imagine. Stacy, anything? Oh, I don't think your mic's working. Is your mic still not working, Stacy? Feel free to chime in if you want to add anything about ISAC.
Mimi, can you share any updates about expectations around the federal grant process?
Yeah, thanks, Amanda. That's a great question. We'll know. I anticipate that we're going to find out at a meeting next week that all awardees across the nation will participate in with CDC. I suspect we'll find out information about what we can expect for our new grant that begins July 1. We're at the tail end of a grant that we started in 2019 that was extended a couple times. So the word on the street, I don't like conjecture. I think people at the program are really tired of hearing me say that. I don't like to participate in conjecture, but I will say that the people, the Association of Immunization Program Managers and other folks at the national side are saying that they believe that immunization program core funding is at risk for no more than a 5% difference. But we should know that next week.
Thanks, Mimi.
Yeah.
Dr. Patton says it seems a good time for advocacy. Could we review the IPAT charter for guidance about how members can be supportive of your work?
You know, Dr. Patton, I've had that. I have a little folder on my desktop of IPAT. It's called IPAT Reimagined. It's been there since February of 2020. And I'm ready to pull it back up and get it live again. So thank you for saying that. And I will pull that up and reach out to members to get some help and guidance about how best to do that. And do you see if Dr. Cisak is here yet?
I think his meeting lasts till 1, Mimi, so we have some time. But
yeah, we have the replacement project. So yeah.
No, he's not here yet.
Okay. Please, we can move on to Mike Day's piece of this agenda, but we also have some time before Paul is able to arrive. So if you think of any questions about anything you've heard today or even things you haven't heard today, we can come back to a Q&A as soon as Mike is done.
right. And if we do have some time before Dr. Cislak arrives, we could also do a roundtable and see if any of our participants have anything to add. Because I know you'll want to stick around and hear what Paul has to say about respiratory diseases.
There's some surprises, that's all.
Yeah. Mike, if you would take it away, please.
Sure, I can do that. Although I'm only going to be a few minutes, it's not a large update. There's massive amounts of work happening, but it can all be described in a few minutes here. I'm Mike Day. I'm the Alert IS Deputy Director, and I work with Jenny and Katie on the replacement project, and they're not able to be here, so I'm covering that today. Kind of three main points at the moment, or three highlights for this. Of all of the work that's going down, we're heavily in project management world. It's the planning phase. There's lots of that happening. Lots of people, lots of work on that. But the three kind of highlights for today's meeting, the first one is we have selected a vendor for an independent quality management services. It's called IQMS. If you ever hear that acronym, it's an external independent quality assurance. So with IT projects of this size, we have to hire an independent contractor to check the work that we're doing it in the right way, provides input to us on our strategy, an approach, make sure we're meeting the national standards that we're trying to get to with the replacement project, and really just to help better ensure the success of the project. So vendor has been selected. The contract is not yet in place, but that's expected by the end of this month. And once that's done, there'll be regular meetings between the vendor and our project team. And I'm sure we'll hear more about that. We'll be presenting more about that here to IPAT as we get further along in our work with that vendor. So that's kind of an exciting step. It's a major project milestone to have that on board. And having been in projects both with and without IQMS, I definitely see the value in having that external view to help reassure that we're being good stewards, we're doing what we're supposed to be doing, and catching some things that maybe we overlooked. So it's always a worthwhile to have that. So that's the first one. The second thing that we're really heavily in is preparing for our request for proposal. So the RFP, which is the formal solicitation documentation to go out to the vendor community and have them submit proposals to meet our needs. There's a lot of background work that has to happen with that, a lot of documentation. We're working with DAS procurement services and DAS enterprise security, so making sure we're meeting all the security standards and all of this. So there's a lot of detailed documentation happening. Our objective is to have this posted, the RFP posted by the end of this year. And then the timelines will flow out from that. If we're looking potentially at about a 2-month period for the proposal to be up and active, and then timelines after that for reviewing and making selections and all of those other pieces that happen before we can start moving forward with contracting. So end of the year is our goal for getting an RFP out to solicit for this. And the final piece, and it's related to that RFP because it's a key component of it, is finalizing the requirements for our replacement system. We've drawn on, there's a lot of national standards in play. There's a template that the CDC has endorsed for what IISs, the requirements they should have. We are working from those and updated it with some, specific to Oregon. We have some more exacting items, for example, that we're looking for example, in school law pieces that aren't directly part of the national standards, because Oregon has, its own differences there around school tracking, as well as trying to integrate our current school tracking of exemptions and exclusion letters, incorporating all of that into a new IIS. Currently, there's 2 or 3 systems that need to be used and a lot of manual work. So we're trying to incorporate that as well. So our subject matter experts have been heavily involved in working through those, making tweaks, and working on benefits documentation from what those requirements are going to give us that we don't have now, for example. So there's a lot of planning work going on. It's taking up a good chunk of time, but it's definitely moving the project forward. And I think we're in pretty good shape there. So That was the update I had for the replacement project today. I know that Katie, our project manager, was going to try to make the call here when she got done with an earlier call. So I'm not sure when might be available for any questions, but we can follow up with any questions that you might have if I'm not able to answer them. So I think that's all I
Mike.
have. Thank you. Yes.
I was just going to say it probably feels like a long time coming to people that are outside the process, but the concept of posting an RFP by December is really exciting. I'm not sure if people are aware, but for us, that's when things really pick up because once a vendor is identified, then we can start making the adaptations to the system we're acquiring and really get our hands on it and figure out how it's going to be used. So that's pretty exciting.
Yeah, I agree with you, Amanda. Do you see Dr. Patton's question, Amanda?
Oh, does that vendor serve other states already? Thanks for pointing that out, Mimi.
The IQMS vendor, I don't know actually. That would be a Katie question. I'm not as familiar with that side of it as I am the IIS vendor side of things.
And they may not, sorry.
We'll find out.
I was going to say they may not specialize in IIS specifically either, because they can potentially just be specialists in that quality assurance process for data projects without having a focus on IIS. So I know they had to meet certain qualifications in order to apply. Any other questions?
Madam, having Mike go did make me want to say and repeat again that with Project Horizon, as well as things like IPAT, I want people to know that the program values and protects our IIS above everything else, because it is the foundation of almost all of our other work. Our VFC program relies on the IIS. Our ability to respond and react to emergencies and outbreaks relies on the IIS. Nearly everything we do. So that is our core work that we protect in an environment like this.
Well, and for people who might not have realized it, COVID, I think, really brought that to the forefront, how much we relied on it to get COVID vaccine out to folks, to track how well it was being, how well people were taking it, et cetera. Dr. Patton?
Can you remind us the why of why we have to update the alert? And is there a crunch timeline at the end as we're losing staff that is going to be a problem? Or is this just sort of, remind us of the why?
Yeah, I can take that. There's several reasons. One is alert is now, well, for us, it's about 15 years old since we originally contracted. The system itself was originally developed about 25 years ago, the very first pieces. And just in the IT world, even in large scale IT systems, that's a forever. There are several things that the IIS does not currently do that we would like to have. It's not very mobile device friendly. Accessibility is one of the things we're looking to improve. It will provide public access to immunization records directly, that we don't have that capability in the current system. And then just being a modern IT system so that it's more easily maintained. If there's disaster recovery needed, it can happen more quickly. It can expand more easily if we need to, a pandemic situation, suddenly we need to double the capacity of the system in terms of processing records. We could do that. So generally, that's the main piece. We do have, I don't think any of the current staffing things that Mimi talked about are directly impacting this, but there certainly is some impact from that, just with potentially losing some of our subject matter experts. So it falls on those that are left to pick up a little bit more of the load. So there will be an
Speaking
impact.
of Mike, do you want to mention your retirement?
Yeah, I was just gonna, that's where I was heading with that. So I am one of those, and I am retiring on April 1st. So we will be in the RFP, hopefully selected or close to selecting a vendor then. But even more generally, just, people's lives go on and they end up in different places, and it's difficult to predict sometimes whether somebody's going to be able to hang around the whole time or not. So so all of that together, there's always some challenges on staffing. And it looks like Mimi wants to.
Yeah, thanks, Mike. There is a wave of retirements coming in public health. I think it started a few years ago, but Dr. Patton, it's a great question. So while we are really doing everything we can to protect the IIS, there will be secondary impacts. For instance, we're going to lose some of the staffing we're losing is on our help desk, which means people will have consumers and providers will have likely have less rapid response and technical assistance, and there will be demands on core IIS staff to help solve some of those technical problems that our help desk staff now takes care of.
On a maybe slightly more positive note, in response to Dr. Patton's question, I would like to put in a plug for the forecaster. Many of you may have noticed that there are certain vaccines that we can't forecast for now, or we can't forecast for correctly in the IIS. And that again is because of the limitations of an older system. So one of the things we anticipate that the new system will do is match ACIP much more closely and be able to be updated more quickly, with less of someone like me sitting back there trying to puzzle out how to make this work. Since Alert was implemented, we've gotten another half dozen different vaccines, all with different schedules. And every single time we think that ACIP has explored every variation of how to forecast a vaccine, they make something up. So that's probably not true, but it feels like that to me sometimes. So that is one of the benefits that I think providers will see most directly, is having clinical support guidance that is much more accurate. All right, so I'm not sure. I think Paul's supposed to be here in about 10 minutes. Anne, is he here yet?
Nope, no sign.
Okay, so
waiting for the Easter bunny.
You think he's bringing candy?
Well, we can hope.
I would like to open it up for roundtable. If you've got anything that your organization is working on, or anything you'd like input on from other members, or just have something to share, please feel free to come off mute and share with all of us. We'd appreciate it. Teresa.
Yeah, hi there. I feel like I mentioned this at the last meeting, but don't remember. It's kind of somber, and I hate filling space with somber things. But for anybody who didn't make it, or if I am forgetting and I didn't say it, our Multnomah County Health Department Community Immunization Program is sunsetting. It was almost exclusively ARPA funded, and those dollars have gone away. And our very last clinic for our immunization program will be on June 13th. So putting that out there, we're still working on how we're going to best support our healthcare partners and insurance partners and community partners to help fill some of the vacuum that's going to be left by that program closing.
Thank you for sharing that. That is disappointing news. I know that it can be very complex for people who need immunization only appointments to find access, particularly in the metro area. You would think it would be simple, but it just isn't.
Oh, this is Cindy. May I ask a question?
Absolutely.
So I'm curious, will Multnomah County still have like vaccine only appointments in clinics, or are all of their vaccination services being eliminated?
Yeah, I'm glad you're asking that clarifying question. I maybe made things sound more dire than they are. We have a system of federally qualified health center primary care clinics through the health department. Their vaccine operations will not change related to this. This is our public health operated vaccine clinic that only does vaccination.
And so will the FQHCs provide vaccination to clients who are not a primary care of the FQHC?
We've had that conversation with them. There's not currently an avenue for them to vaccinate folks who are not assigned to them for primary care, not registered for primary care in their spaces. But it's something we've been trying to hash out and haven't quite gotten there yet.
Gosh, yeah, that is significant loss. Sorry for that.
Yeah, it's particularly concerning, I think, for kids who are seen by providers that don't provide immunization, because I still think there's an underlying assumption that they can just refer to the county health department and the county health department will vaccinate. And that access just isn't there in the way it used to be. So,
yeah,
Lisa?
100%.
Oh, sorry, Teresa. Lisa?
We've been concerned about that in Lane also. And I'm curious, like, have you guys come up with any ideas of where to refer, especially kids under 7 that can't go to a pharmacy? I'm
Lisa,
just,
to Dr. Everson, or do you mean?
in Multnomah specifically. I mean, we struggle. I mean, we're in a horrible healthcare desert here in Lane County with Optum Health buying out Oregon Medical Group. We just lost a lot of our provider care and community here. And so that's what we're most anxious about. And that's like kind of what we're focusing most on in our ME clinic is especially those peds under 7 that have no other resources. You know, that's what we are as a safety net. And so we're so worried about what the future is going to hold. And
Yeah, we have the same concerns. The irony of all of this is we had an immunization program pre-COVID that sunsetted in 2019 and then had to stand up operations again quite quickly when we had COVID vaccine to distribute. So we've been through this before, but I'm not sure that in that time there are new great resources for our folks who truly have no access anywhere else. And we're still trying to figure out what the answer is going to be. It's a terrible situation.
Kelly, I wonder if I could ask you to pop on real fast and talk about the University of Washington study and what people can expect to learn from that when we're ready to release it.
Sure. Yeah. Hi, everyone. Kelly again, Immunization Policy Project Manager. So we have contracted with the University of Washington for the last several months on a series of tasks designed to really identify where the barriers are for providers to enroll in our state supplied vaccine programs like the Vaccines for Children program and Vaccine Access program, and to identify, sort of that downstream impact on access in communities where we're seeing fewer providers. So we had a survey that went out through our listserv. Some of you shared that within your channels, and that was really helpful. We had key informant interviews with about 30 clinics, some enrolled, some not enrolled. Also conversations with folks who are not enrolled as to why, or if they disenrolled, what were the drivers of that. And so, yeah, we're wrapping up this project at the end of this month. And then I hope to be here before you to share some big picture overview at the next meeting. Really, we're seeing that the barriers are what we expected to see. So the cost to be an immunization provider is a real barrier for many clinics, particularly to be enrolled only in VFC and then purchase a separate stock of vaccine for your privately insured patients, that is cost prohibitive for some, particularly for clinics that have just one or two providers and maybe a high number of VFC clients, but not a lot of privately insured. That is an issue. Challenges, just sort of administrative burden of managing multiple programs. So that patchwork that I've talked about here before, where some clinics have, VAP clinics have their 317 funding for uninsured adults. They've got VFC, and then they have billable vaccine for those clients, and then we're not able to provide a couple of vaccines now for as billable vaccine for those VAP clinics. So that then adds some locally owned vaccine and private purchasing. So it's just gotten really administratively complex. We are seeing a lot of feedback about continued staffing shortages, or just hiring and then having turnover, or being able to hire staff that it then takes quite a long time to train to get them up to speed in immunization. So I think that you'll see that the findings resonate with what we've been talking about and what you would expect to see, but it will be very nice to have some data to share with you, because we have been speaking anecdotally about this for a long time, and so now we'll have that.
I want to add, Kelly, that there is some hope for improvement if Senate Bill 42 passes and is funded. There's about 50 clinics on our waiting list that want to join that program, and in the areas where those clinics exist, it will ease access to a certain degree, and some very clever and unique kinds of providers who want to join. So there's hope.
I'm also hoping that because Senate Bill 42 asks for a one-time infusion of funding, that may make it more palatable.
I agree. That's true, Amanda. And if it's funded at the current amount that's included, that would provide some a bit of breathing room for our vaccine access program. We would be able to enroll the wait list. It'll take some time, of course, and we'll need to prioritize because there are over 50 clinics there. If it passes with a reduced funding amount, it's possible that we will just maintain status quo, which means our enrollment in VAP will continue to be paused. We won't be able to grow it. And so as we have new providers, that are starting out and looking at that big price tag to be a VFC provider and can't, it's cost prohibitive to purchase the private stock of vaccines, VAP will not be an option for them. And so, we just don't know right now what to expect. And the other piece is that, we had our vaccine finance reform steering committee. We've talked about that here many times over the last year plus. And that ended at the end of September with recommendations that ultimately led to Senate Bill 42. And, that group, their other recommendation was to continue with another task force or work group that builds on the work of the steering committee. And so we're hoping to see that stand up as well later this year. The committee who's working on that small group from the steering committee, is waiting at this point to see what happens with Senate Bill 42, and then we'll turn their attention to a potential next committee.
I'd like to think about it as a lot of you have seen Kelly's image and heard her talk about the ecosystem of immunization services in Oregon as a patchwork, a fraying quilt. If Senate Bill 42 passes, it will add some structure to that existing quilt, but it will not sustain it for long. The current system is unsustainable, and the evidence I have to back that up is the number of states that are seeking universal purchase programs. The latest of which is Hawaii. Their bill did pass. They're jumping into implementation planning now. So that part about carrying on the advisory, the study into whether and how to make universal purchase work, if possible, in Oregon, really needs to happen. And yeah.
Amy, did you want to discuss Deborah's question more broadly with everyone about COVID vaccines and updated forecasting and anticipation of what COVID's going to look like?
Paul is prepared to talk about that, and you probably can speak to it better than I can, but I think the core of Deborah's question is, do we anticipate a struggle getting vaccine for VFC providers who have a population that want and will continue to want to be vaccinated? And I think the answer to that is, I don't anticipate a struggle there.
And I would agree with that. I don't think there'll be a problem for clinics that want to order it. I think the big
Paul is here.
challenge. Oh, good. I think the big challenge here, and Paul will address this, is that instead of sort of being an automatic, now a specific conversation is going to need to happen in order to make sure kids get COVID. So, but I will defer to Paul. Paul, thanks for joining us. Are you ready to present?
Well, let me see if I'm ready to present.
Sorry that you're having to jump from one meeting right into another. That's challenging.
That's okay. Let's see. What do I do here? I gotta press share screen or something. Share.
That should work.
There we go. Let's see. Let's try that.
Ah, yes. We can see that.
Excellent. Let's see. Then you can turn my video on, I guess. I don't know if that matters. Okay. Are you seeing sort of full screen?
Looks good.
You don't want to see this stuff though, do you? Okay. I get this out of here. Okay. All right. So this is just kind of an update of where we are on various vaccine preventable diseases. COVID-19, I'll start with COVID-19. Test positivity is down since mid-August, although we've seen, if you look at the tail end of that line, you'll see a little bit of an increase. I guess I could have updated it more recently, but 17th of May, we were at 3.7%. So it remains to be seen whether this is the start of a summertime surge that everybody's wondering about. But that's still a pretty low percentage historically. So this graph shows basically, going back to the beginning of the pandemic, and you'll see all the various waves and, the Delta wave, the Omicron wave, et cetera. But pretty low right now. And that's confirmed in our COVID-associated hospitalization rates. It's not reportable in Oregon, but we do get voluntary reporting of hospitalized cases with COVID from the Portland Tri-County area. The population there is 1.8 million. It's about 43% of the state of Oregon. So we think it's a pretty decent reflection of what's going on statewide. But you can see that hospitalizations have been trending downward since January. And you can also see the preponderance of hospitalizations in persons 65 years of age and over. About 4% of all the hospitalizations have been in persons less than 18 years of age. This shows COVID deaths by week, and they're also really at historic lows since the beginning of the pandemic. This is a really interesting graph that you can produce by going on CDC's website and tweaking a few things. But you'll see that the test positivity, which is shown in orange, in the orange line here, correlates very closely with hospitalization or COVID deaths by week. until you get after the first Omicron wave, and there the curves diverge. And so really, since we got through that first Omicron wave, end of January of 2022 or so, there's been, these big peaks in COVID test positivity that has not been matched by commensurate peaks in deaths. So the disease does seem to have become less severe. I don't know whether that's because Omicron is inherently less severe or because we've all seen it by then and have some underlying immunity and probably a few doses of vaccine as well. What's going on lately is that this JN1 descendant, known as LP.8.1, has become preponderant over the last several weeks, and it's shown in the orange bars here. And so FDA recently came out with their advice. The VRBPAC, the Vaccines and Related Biologics Biological Products Advisory Committee of FDA, unanimously voted to recommend a monovalent JN1 lineage vaccine composition. Following the vote, the committee discussed considerations for the selection of a JN1 or a specific lineage strain for COVID-19 vaccines for 25-26. And then FDA issued this statement: based on the totality of the evidence, FDA has advised the manufacturers of the approved COVID-19 vaccines that to more closely match the circulating viruses, the vaccines for use beginning in the fall of this year should be monovalent JN1 lineage based, preferentially using the LP8.1 strain. So that's the strain that was in orange on the last slide that has been preponderant for the past couple of months. And this is a nifty graph that CDC maintains, and it shows the evolution of the variants. And here I've circled the origin strain back in January of 2020, and then here's the BA.5 strain, which went into the first upgrade of the vaccine. That was a bivalent formulation, and then XBB 1.5, and then finally here's JN1, and then almost everything that we've seen since then has been descendants of JN1, and the LP8.1 strain you will see there in the upper right corner. And it is thought that anything JN1, that all of these JN1 descendants, you're probably going to get significant immunity, at least against severe disease, from having contracted JN1 or been vaccinated with such a strain. Okay, Mimi asked me to say something about recent FDA pronouncements and CDC pronouncements regarding COVID-19 vaccination and who it's recommended for. After all is said and done, and feel free to correct me, but the only difference that I can really detect in the recommendation is that they're saying that they are not going to recommend vaccination routinely of healthy kids 6 months to 17 years of age. But other than that, I think the recommendations are basically the same, that all the adults should get a dose of the vaccine. And, of course, if they've never been vaccinated before, then the appropriate priming series with Novavax if they've never been vaccinated before. And that persons over 65 can get 2 doses, and immune compromised people can get more than that. But they are still recommending on at least on a shared clinical decision-making basis, vaccination of pregnant women and of kids with high-risk conditions, 6 months to 17 years of age. So functionally, I don't think it's going to change who is able to get vaccinated if they want it. But feel free to correct me if I'm wrong about this. This is my read of what I saw on CDC's website recently. Okay, moving now to influenza. I keep track of when does influenza peak every year, and I look at test positivity, and the most common month for influenza to peak has been January, and then behind that a little bit are February, March, and December. However, the last 3 seasons, the peak test positivity anyway has been in December, and this year it was the very last week of December during this season. Oh, there we go. Nationally, they can look at pediatric mortality. So this is, anyone under 18 years of age who dies of flu, and they recorded 235 this year. An average is about 160 a year. So I think we had a higher than average year this past year. And as far as our recording of hospitalizations anyway, in the Portland Tri-County area, which is where we track it, this was our worst season since we've started doing this 20 years ago. We had, I want to say 1,700 hospitalizations in among Portland area residents with influenza. You can see in the blue bars that the vast majority of them are influenza A. And then as we commonly do, we saw some Bs coming in near the end of the season, but they still accounted for, I think, only about 4 or 5% of all of the isolates for the season. Test positivity, again, peaked during this last week of December at 31.6%. And, we have stopped tracking this because we met criteria for season offset. And when last checked, it was at 2.5%. If you look,
should that be 2024, 25 at the bottom?
Yes. Sorry about that. Oh my gosh. Yes, you're absolutely right. This is 2024 and this is 2025. Yeah. Okay. And nationally, you can see that about 50% were H1N1, 45% were H3N2, and 5% were B Victoria. This is hospitalization. So here's the 1,748 hospitalizations that we had. 53% of all the hospitalizations were these purple boxes, which is adults over 65 years of age. And we had 100 hospitalizations in kids under 18 years of age, which are shown in the green and blue at the very bottom. So 5.7% of all hospitalizations were in children. This shows influenza vaccinations by week. We slid a little bit from last year's total. I think we had 1.3 million about 1.3 million vaccinations, are only about 29% of the population. So, we could still do a lot better in getting our population vaccinated. There's been a lot of talk about high pathogenic avian influenza, H5N1, which seems to have become enzootic within our bird populations in the United States over the past few years. And we are on a Pacific flyway, so lots of birds flying, north-south over these states. And these are human cases of influenza H5, 70 of them in the past couple of years, with California and Colorado leading the way. Of the 70 human cases, 41 are thought to have acquired their influenza AH5 from dairy herds. So, there have been variants of influenza AH5 that have gotten into dairy cattle herds, and the cattle can carry it for quite a while, which puts, those who are working with the cattle at risk for some period of time. And so 41 out of the 70 from dairy herds. 24 of the cases apparently acquired it from poultry farms and such. There were 2 that were from other animal exposures, and in 3 cases, the source was unknown. Okay, moving on to respiratory syncytial virus. So we declared season offset after 2 consecutive weeks of dropping below 3%. So in late April, we were able to declare the end of the RSV season. The peak was the week of February 2nd through 8th. And when most recently, in the most recent report, which was as of 17 May, PCR test positivity was 0.6%. This shows hospitalizations. We've been doing this for fewer years, as you'll see on my next slide, but this was kind of an average year, 466 RSV hospitalizations. 34% of them were in kids under the age of 5, and about 35% were in adults over 65 years of age. And this shows age breakdown for several seasons, and you can see that overall, this was sort of an average season. A worse season may have been 22-23 and 2019-2020. Okay, well, if you've been paying attention, you'll know that pertussis has really been walloping us since early 2024. When you look at the curve of incidence of pertussis going all the way back to 1915, here's the little blip that we've been seeing recently, and maybe it doesn't look all that impressive, but it is the highest total that we've had since 1950. Yeah, I got some vaccination dates in here. So this just shows you the last 20 years worth of data, and you can see how this number sticks out. We thought this was a bad year at 910 cases, but last year we had 1,259. And it hasn't really let up yet. So this is showing weekly totals since the beginning of 24, and you can see that even in 2025, we're seeing very high weekly counts. So I'd like to think that we were coming off the peak, and I did think that for briefly, but it has held up, and we really haven't been dropping much. You can attribute some of this to lag in reporting, probably. Now, remember that who gets hospitalized from pertussis is disproportionately the infants, shown in the blue shaded columns, and 312, and I think like 65% of them or something like that were infants. But remember that around 2014, we started this recommendation to vaccinate all pregnant women against pertussis so that they can make antibodies and transfer them across the placenta to baby and protect the baby from the moment of birth. And we've had far fewer infant hospitalizations since then. And when you look at 2024, remember, sort of record number of case counts for this time period, and yet, only a handful. I want to say that number is 11 hospitalizations in 2024. Compared to some of these totals in years before that recommendation was in place. And we have, other more precise studies that have demonstrated that, it is probably 90% effective in preventing hospitalizations among infants under 2 months of age who are at highest risk. They haven't had any doses of vaccine yet. So, one thing we're really interested in is of the infants who do get hospitalized with pertussis, did mom get the recommended shot beforehand? And you can see that disproportionately it's occurring among infants of women who did not get the recommended Tdap during pregnancy. Okay, measles is all the talk, of course, given the outbreaks in the rest of the United States. This is Oregon's curve. We had a sizable outbreak last year in Marion and Clackamas counties. This Multnomah County case was not related to these outbreaks. And again, all of these cases were unvaccinated. Control measures for when we're seeing measles, well, obviously we'd like to get everybody up to date with MMR and we wouldn't have an outbreak. But when you do have measles in the area, and if preschool age children are at risk, remember the recommendation is typically to get a dose of MMR at 1 year of age, and then at the preschool visit. And but if measles is in the area, you can give that second dose, as long as it's given 28 days after the first dose, it's a good dose. So you could give that early. And then if infants under 12 months of age are at risk, either because they're part of a community where measles is circulating or they're traveling to an area with their families, you can consider giving a 0 dose at 6 to 11 months of age. Doesn't count toward meeting your 2-dose recommendation because we don't know that it'll work, but it might, and so it might be a way to add some protection to your infant. I still maintain that control of measles has been a public health victory, and I am showing you the like 31 cases that we had last year, but the number is so small it's dwarfed by the thousands of cases that were occurring in these years before the advent of live attenuated measles vaccine. So, it could get much worse, and we're managing to keep it at bay. But when it lands in a pocket of unvaccinated people, as it has in Texas, then you can see it spread like wildfire. So briefly, with the outbreaks in the rest of the country, we don't have any measles yet this year in Oregon. But I think there have been 1,088 cases reported nationally. Something like 742 of them are from Texas. And most of the cases, of course, are associated with that outbreak. Gaines County, Texas is a sparsely populated county on the New Mexico border. Its population is around 22,000, something like that of the population of Hood River County, Oregon. And that one county has over 400 cases of measles, so that was clearly the epicenter of the outbreak. Okay, Mimi or Amanda, stop me anytime if you want. I could go on forever. I do have some slides on Mpox.
Well, I was going to say, can you talk a little bit about the plan to do wastewater testing for measles? Or just that we're going to do remote?
Yeah, just that we're going to do it. So, we've for the past several years with COVID money initially, and now there's sort of a wastewater surveillance funding that we get from CDC. We started testing wastewater for various viruses, particularly COVID, but also influenza, RSV, things like that. And the nice thing about testing wastewater is, you can, sort of test the population of Portland by going to one place, because those of us who live in Portland are all making deposits into the wastewater system and collect it and test it for viruses. And the technology is good enough where they can find it. They can actually, if there's enough of it, they can sequence it and tell you, what strains are circulating and whatnot. And they're not dependent on you or me going to the doctor and getting a test the way traditional surveillance methods are. So if you're talking about a disease with a lot of asymptomatic transmission, like COVID, it's testing wastewater is a good method. So one of the things we want to know is measles circulating? Because it's not necessarily going to come to the attention of the doctor. Some of these communities that aren't vaccinating are also not eager to take their kid to the doctor and get diagnosed with measles, even if they're suspecting it. We know that we missed some cases during last year's outbreak based on gaps between reported cases. And our recommendation for testing is pretty dramatically different based on whether there's measles in the area. If there's no measles in the area, then your likelihood of any given rash being measles is really low. But if there is measles in the area, it goes way up. And in fact, we lower our threshold for testing at the state public health laboratory. If there's not measles in the area, we generally say, well, send it to your local commercial lab and we'll hear about it if it's positive, but it probably won't be. But so we want to know if it's in the area. So what we've done is picked some areas, mostly in wastewater systems that are serving a larger number of people, and then in lower vaccinated areas. We don't have enough funds to do it statewide, but we're sort of picking a bunch of areas around the state where we think we might be more likely to detect it if it's here. So that's the plan. We haven't started doing it yet, but I hope I can look forward to showing you that at some future meeting, or somebody can look forward to showing you that.
Mimi, do you want to go ahead and share what you just put on the chat for those people who might
Yeah.
not see it?
Just read the chat about if you didn't get the list, don't get our list serve that we're getting ready. We just launched yesterday a Get Ready for Measles project. And then Amanda, Dr. Braun's got a question for Paul.
Oh, great. Do the live virus vaccines impact wastewater results for measles, or will the sequencing be able to show it's from vaccine?
The sequencing will be able to show. Yeah, that was, of course, our first question, because there's going to be far more people getting measles vaccine, right? I mean, if 90% of our birth cohort is getting it, that's going to be over 30,000 people getting live virus vaccine. And we have very few cases of measles. So yes, we thought about that, and they can distinguish.
Great, thank you.
Do folks have questions you want to ask Paul, or would you like him to go into MPOX? And Paul, I want to remind you that you have an announcement to make.
I do?
Yes, sir, you do.
Okay. Well, okay, I just have a little bit on MPOX because case counts have been pretty low. You all will remember that we had a sizable outbreak back in 2022 and started recommending Jynneos vaccine for persons at high risk based on sexual risk factors. And 322 cases reported in Oregon as of a week ago. And here's the counties where they're located. I think 65% or so, 64% were from Multnomah County, these 207 cases, and then a smattering of cases in other counties, mostly the more populated ones. By age and sex, 97% of the cases are male. So it was primarily affecting men who have sex with men. Yep, that's it. I can end it there. I mean, I sort of started reviewing all of our vaccine preventable diseases, and but I should stop there and take questions.
Are you going to share your news?
My news is that I'll be retiring from the Oregon Health Authority effective the 1st of August. And I think my last day in the office will probably be around July 18th. So it's been 30 years, and it's been a lot of fun because in this line of work, it's always something. You can go back to the beginning, and we had prion disease, concerns with bovine spongiform encephalopathy back in the late 90s. And then we had West Nile virus marching across the country, and we had the anthrax outbreaks that we had to worry about. And I think it was 2003 that the first SARS hit, and then we had pandemic flu in 8-9, and Ebola virus concerns after that. And of course, MPOX is maybe COVID goes without saying, but MPOX is maybe one of the newest ones. So it's a lot of fun. I've always loved the feeling of not knowing, getting hit with something that I don't know anything about, and having to, hit the books and being on the steep end of the learning curve. But that's what has kept the job interesting. And the other thing that has kept me here for this long is just great colleagues to work with. We've had a great corporate culture here that is mutually supportive, and a lot of people working hard to try to do good work. And it's just, they're valued, and it's very satisfying to work in an environment like that. So thank you all for 30 wonderful years.
And I just want to add, that you don't have to miss Paul, because he's going to join IPAT when he retires.
Can't stay away.
Oh, I'm so glad to hear that. So glad to hear that. I also have been here 30 years now, as of August 1st. So, and yeah, it's been interesting. If it isn't one thing, it's another. Keeps me engaged. So, Paul, make sure you take a look at the chat to see all the well wishes.
Oh, thank you. Bless you all. Thank you.
Okay, so I think we're ready to wrap up. Is there anything that folks want to see on the next agenda? If so, it would be great if you would put a note in the chat and we'll see if we can't address that next meeting. Mimi, can you share with us when the next meeting is?
I can. Give me 1 second. Anne might beat me to it, though. Let's see. It will be September 4th. No, yeah. And I won't be here because my son's getting married.
That is also very exciting. I will share on a personal note that I got my son graduated from high school yesterday.
Yeah, hooray, Amanda. Congratulations.
I have photographic evidence.
Yeah.
And if you're wondering if it was by the skin of his teeth, yes, it was. Yes, it was.
Or yours.
Or mine. So anyway, thank you all. Thanks for joining us. It was really great to see folks from Eastern and Southern Oregon here, as well as folks from the metro area. So I hope you'll join us on September 4th, and I'll plan to be here.